Today we are talking hormone replacement therapy. We have questions. There's a lot of confusion, a lot of conflicting information, even though HRT is one of the most well-known treatments for menopause for managing menopausal symptoms. Here to walk us through it is Dr. Jennifer Zelovitsky. Hello.
Hi, Gina. Hi, everybody. It's great to be back with you.
So I said to you before we popped on today, we're talking about the medical side of things. We're talking about testing. We're talking about treatments. And you're like, this is my jam. Bring it on.
This is my bread and butter. This is what I do all day, every day. Talk about this stuff, learn about this stuff. It's an evolving field, as many of you know, which leads to a lot of the confusion and misinformation out there.
So do we need to go back and talk about what we thought, or do we just move forward? Because there's been a lot of confusion around HRT. I know there was studies that came out years ago, and everyone's been afraid to touch the stuff ever since. I know the research and the science and the data has changed. Do we need to go back, or do we just move forward? Where should we start?
Important too, because it does come up in almost every conversation that I have when I'm counseling patients around hormone therapy, is we need to understand how we got here to truly give women the reassurance that they need to have about the safety and where these misunderstandings came from. So 20 years ago or so, a little over 20 years ago, there was a huge study done by the FDA called the Women's Health Initiative. This is the famous trial where they had about 27,000 women enrolled, and they had a hormone arm of the trial. And this was also divided into two different groups. Women who had a hysterectomy, didn't require any progesterone for reasons that I'm sure we'll get into. So they were given estrogen alone. Women who had their uterus had to have estrogen plus progesterone. And so those were two separate groups, each one against a placebo. And interestingly, there's a couple of things you need to understand about this study. They took postmenopausal women aged 50 to 79, some of whom were 30 years beyond their menopause. Most of them were asymptomatic, meaning they didn't have symptoms of menopause, because they really didn't want for women to be able to tell if they were on a placebo or not, because that can skew the results of the trial. And the whole point of the trial was nothing to do with menopause symptoms, but to see if hormone therapy could prevent disease, heart attack, stroke, osteoporosis, diabetes, breast cancer, you name it, a whole bunch of things. And they followed these women along. Now, after 5 years, the estrogen only group, this was a group with just estrogen, had a 23% reduced risk of breast cancer across the board. And this persisted over the next 20 years. They never saw any additional deaths related to breast cancer in that group. In the estrogen progesterone group, they saw a very tiny, not statistically significant increase in breast cancer compared to the placebo group. We're talking 8 in 1,000 women diagnosed with breast cancer. As they stated themselves in the study, this does not reach statistical significance, which in science terms means it could easily have been due to other factors. And in fact, there are scientists who have unraveled what those other factors were. And most importantly of all, over the subsequent 2 decades, we've discovered that all of the risk was for women over age 60 when they started hormone therapy, or 10 years after their menopause. This led to the current guidelines that we try to start hormone therapy within 10 years of your final period or during perimenopause. So I hope that gives everyone some reassurance, because they did see reduction in osteoporosis, heart attacks, strokes, breast cancer, diabetes, colon cancer. There were so many benefits, and those got masked by this tiny, non-significant increased risk of breast cancer.
Well, we all know how they like to glorify headlines.
Exactly.
So really interesting, because my takeaway is this study for HRT wasn't really about trying to help women with their symptoms. They were just trying to study maybe the benefits beyond as women got older. So that's the takeaway. The other takeaway is that although the study was done and the concern is women over the age of 60, so the takeaway is the earlier you can start it, the better. It doesn't mean that there aren't benefits or you can't take it beyond the age of 60.
Well, I think it's worth a discussion with your doctor, because the rule is actually 10 years beyond your final period if you're postmenopausal. So for some women, that's 65.
Yeah.
So 60 is a substitute for when you're not sure when your menopause was, or maybe you had a hysterectomy, so you stopped bleeding, but you're not quite sure when your ovaries actually stopped functioning. So we take the average age of menopause, which is about 50, 51, and we extrapolate from that. Then if you're not sure, then you go with 60 to be safe. But it all depends on a woman's overall health. I have had the discussion and counseled women carefully who are a little bit older than 60 and have made the decision to start hormone therapy because I felt they would still benefit in terms of their symptoms. But in terms of benefits, it doesn't appear the benefits exist beyond 10 years. And the reason is the estrogen receptors do start to downregulate 10 years after menopause, right? So you're not going to necessarily get the same effectiveness. But if you're having a lot of hot flashes or other symptoms and you're 62, 63, certainly it's worth a discussion to have menopause therapy just to handle those symptoms.
Okay, so this is why you need to have a discussion with your own healthcare provider who understands your health history and can help advise you. So this is also where, as you get older, if you have been taking hormone replacement therapy, they are suggesting maybe start weaning you off that because that's something that's happening naturally anyway.
That's fake news now. So that is no longer the guideline recommendation. And this is important for women to know, because even if they're lucky enough to have a doctor who is well versed in menopause care, or at least has some passing knowledge of it where they're comfortable to start them on it or have the discussion, we used to think you should stop after about 5 or 10 years. This again was based on the Women's Health Initiative findings. There was an assumption that since more of the risk was in women older than 60, that must mean continuing it beyond 60 must be dangerous in some way. Now we have a lot of great evidence that as long as you start it in that 10-year window, the window of opportunity, there are benefits to continuing hormone therapy for the remainder of your life, with certain caveats. There are certain things you might be diagnosed with, or things might change in your health history that might warrant changing it, reducing the dose, or considering coming off it. But there is no longer a blanket recommendation that you should stop or wean off at a certain age.
So that's no longer the standard.
No, that's no longer the guideline standards. I'm happy to tell women, because most of them, when they start, they say, I don't ever want to stop this. Please don't make me ever stop this. So it's good news.
Okay, so if you have already gotten on it within that 10-year window, it's no longer the standard to have to get off it. And then if you don't get on it in that 10-year window, is there a benefit to starting it?
Well, that's where symptoms do come into play. So as I mentioned, I have had women that are still really struggling with hot flashes or night sweats, and they are maybe a little older than 60. Some of them, mind you, may have been on hormone therapy at some point in the last 10 years. And that's also important, because then the clock starts from when you stopped your hormone therapy and no longer when your period was. And I have looked at their overall health. And if they are in good health, they don't have any cardiovascular disease, we can consider starting some low dose hormone therapy and see if it makes them feel better. They may just not get those benefits, cardiovascular benefits, that we would expect them to get if they were younger.
Okay, and what symptoms would those be? When you say symptoms, what symptoms would those be?
Yes. So the guidelines stress that the main symptoms for which we consider hormone therapy are hot flashes, night sweats, bone density concerns, meaning that you have low bone density and a higher risk of a fracture or are at risk for a fracture or bone density problems, or vulvovaginal symptoms, so urinary symptoms, vaginal symptoms, then you would be considered for vaginal estrogen. Although vaginal estrogen, I should stress, is safe and a wonderful option for any woman who's experiencing any dryness or discomfort or frequent urinary infections at any age.
Good to know.
Yeah.
Good to know.
However, I want to say to myself and many practitioners like me in this modern age, just because that's what the guidelines say, I often meet women who are not necessarily having the most severe hot flashes, but they are having, 10 or 12 other symptoms that are really disrupting their quality of life. And once we rule everything else out, I do consider a trial of hormone therapy because it is such a safe and effective treatment for so many of the symptoms that we're just recently coming to understand are part of the menopause transition.
In our previous conversation, we talked about the difference between like symptoms and actual health issues. So, what about the benefits of HRT for heart health, for
Mhm.
example?
So we do have a lot of good evidence, even from the Women's Health Initiative, that women who start hormone therapy earlier in life and earlier in their menopause transition, especially women who have an early menopause due to surgery or some other cause, benefit tremendously in terms of reducing heart attack and stroke risk. And the reason is estrogen is a natural anti-inflammatory and has an anti-inflammatory effect on the inner lining of our arteries, including the arteries of our heart and our brain. So when you have less wear and tear and inflammation in those arteries, you're less prone to developing cardiovascular disease. But they also saw in the Women's Health Initiative, in women who started at the right age, they had a reduced risk of colon cancer and of diabetes, also thought to be related to inflammation and the way we metabolize our glucose. And so it's very interesting to see. Now, I get asked a lot about dementia, right? Dementia, sorry, cognitive impact.
Yes,
This
brain
is
health.
it's a bit of a gray area. We have
Okay.
very good evidence that women who have early menopause, premature menopause, do have a reduced risk of dementia if they start hormone therapy. We don't have as much evidence yet for women who are average age when they reach menopause, but we know that it doesn't have a detrimental effect. There's a question mark on whether starting older women over 65 on hormone therapy because it may have a slightly detrimental effect on their cognitive health for reasons we don't quite understand yet. So that's another reason to be cautious if you're thinking of starting it at an older age.
All women are going to go through menopause.
Mhm.
Is HRT the standard of care? Should we all be on HRT?
That's a great question. Uh, there's an argument to be made for yes, in the fact that osteoporosis being one of the guideline recommendations. I mean, theoretically, we're all at risk for osteoporosis after menopause, right? And we're all at risk for a fracture from osteoporosis after menopause. However, we're not quite there yet where we're saying every woman should have it. We're still going based on symptoms. And the reason is twofold. Um, there are studies that suggest that women who have symptoms are at greater risk of the downstream effects of menopause. So, women who have stronger symptoms of hot flashes, for example, tend to be at higher risk for heart attack and stroke and osteoporosis when they get older. Um, and so, for that reason, we have a clear understanding that symptomatic women should likely be on hormone therapy. The 20% of women who don't have any symptoms, they have estrogen receptors that are very adaptive. And so they are less likely, it's less clear whether they're actually going to benefit from the hormone therapy. And we never really like to our motto is do no harm, right? So we certainly don't want to be starting a medication in someone who has no indication to be taking that medication. So in other words, for primary prevention, we're not there yet. We're not recommending it for that.
Is it fair to say that women with receptors that more adaptive are healthier in general?
No, I think that they're just genetically blessed. It's such a minority. You can't control this.
Mm.
Although I should say there are some, I should say there are some lifestyle factors that do influence it. For example, women who exercise vigorously and regularly tend to have fewer hot flashes. And the reason is they are training their thermoregulatory center in their brain to be finely tuned to temperature changes. And so when this disruption comes along at menopause, their body keeps interpreting it correctly. Whereas women who aren't exercising might have more severe hot flashes. But we inherit half of our genetic makeup from our father's side and half from our mother's. And we really don't know what our father's menopause would have been had he been born female, right? But this is why you can't really say, well, your menopause will be just like your mother's or your sister's, because it is a blend. And so some women are just very lucky and they inherit this combination of estrogen receptors through their DNA that are very adaptive and don't respond. It's also a cultural thing. There are certain cultures, Asian women tend to have fewer symptoms of menopause.
Okay. So your symptoms are not necessarily tied into your health.
Not in ways that we can necessarily control.
Okay. Okay. So let's talk about HRT. Who is not a candidate for it?
This is a great question. So there are some contraindications. So we already talked about distance from menopause as being a possible contraindication. It is riskier in women who are 10 years out from their final period. It is riskier in women who have had a heart attack or stroke within the last 2 years. Although beyond that, if they're being medically managed, it can be considered. Women with a history of uterine cancer need to speak with their oncologist, because some women with uterine cancer history are safe to proceed with hormones and others are not. Women who are actively being treated for breast cancer would not be considered. Most oncologists still consider anyone with a breast cancer history to be not a candidate. However, this again is changing as the information becomes clearer about what the Women's Health Initiative actually demonstrated. And again, it depends on how effective non-hormonal medications have been for you, and your own risk tolerance in terms of a doctor saying, we know what we know, we don't know what we don't know. And here are your options in terms of what you might consider trying. So I do have some women in my practice who had early stage breast cancer or who are in remission from breast cancer, who made a very, very well-counseled decision to start hormone therapy. And they're very happy on it. But this is a more intense discussion with someone who's really well-versed in this area of care. It's probably not a conversation your family doctor would want to have with you.
Good to know. What are the risks? I want to get into treatments and HRT specifics itself. But before we get into that conversation, what are the risks with taking? What are we concerned about when it comes to
the main risk is, believe it or not, it boils down to mainly, with uterine cancer, this is a cancer that is stimulated by estrogen. This is the one cancer that we know for sure is stimulated by estrogen. So that's a risky one. Blood clots, which includes heart attacks and strokes, because every woman who's been pregnant or has been on a birth control pill has been told, when your estrogen levels are higher for whatever reason, naturally or through some form of medication, it does slightly increase your risk of a blood clot. These are not high risks. They're small risks. They're higher if you're on oral estrogen. They're lower or neutral if you're on a transdermal estrogen, meaning through the skin.
I want to get back to more of the risk, but I'm going to stop you right there. Is taking HRT any riskier than taking traditional birth control?
Less risky, less. So unlike a birth control pill, migraines with aura, not a problem on traditional hormone therapy. Blood pressure, not a problem on traditional hormone therapy. In fact, it can help reduce blood pressure. Weight gain does not happen with hormone therapy as it happens with birth control pills. We're talking about much, much lower doses of more body identical forms of hormone. Birth control pills are designed to suppress your ovaries and basically trick your body into thinking it's pregnant. So you have this constant high level of hormone. Whereas menopause hormone therapy, or HRT, is a constant low dose of hormones. It does not provide birth control. It does not suppress your ovarian function. It's really like just a little prop up for what your ovaries are no longer giving you enough of. So similar to anyone who's been treated for their thyroid, right? If your thyroid's not making enough hormone, you're getting those effects of that, and they replace a little bit of the thyroid hormone and you feel a lot better. Very different.
So HRT less in general, obviously, generalizing, HRT less risky than probably the birth control that many of us were on at the time.
Exactly. To give you context, a birth control pill will increase your risk of a blood clot to about 8 per 1,000 per year. Again, not a huge risk, but menopause hormone therapy increases it to about 2 in 1,000 per year. And that's for oral estrogen.
Okay.
Progesterone, I should talk about the risks of progesterone. Progesterone can cause, in some women, a little bit of mood disruption, sometimes a little bit of bloating, but that tends to go away in the early days if you bear with it. It can, in some cases, lead to a bit of breast tenderness. But again, I don't see these very often because we're talking about such low doses of things that your body's quite eager to get back. So it's a different animal than a birth control pill.
Okay, so let's talk about testing. For where do you stand on the testing for HRT? Many of us go to our doctors. Our doctors will do blood tests and thyroid tests just to rule things out. So let's say you go to your doctor, they've ruled things out. How do you specifically test for hormones?
So usually you don't really need to. And I love explaining this because it seems strange because sometimes family doctors will make that attempt, right? They'll do the testing and they'll say it's normal, you're not in menopause, or you are in menopause, and you might be having periods, but they're sporadic. So I want to explain what happens. So in perimenopause, which is this 4 to 8 years leading up to your final period, when you're sensing something is changing, and often it is the periods that change in their heaviness, how far apart they are, how close together they are, etc. But you can also start to get, I've seen women who get hot flashes before their periods change, or really bad sleep disruption for no reason, or anxiety out of nowhere. So you go to your doctor. Yes, very important to rule out your thyroid, low iron, look at your B12 because that can affect your mood and your energy. But they come back and they say everything's fine, right? Here's the deal. Those hormones are chaotic and constantly fluctuating in perimenopause. So I might check your blood work on a Monday and it's all in premenopausal levels, meaning your FSH, or your follicle stimulating hormone, is very low and your estrogen levels are very high. But you're 48 and your periods are 6 weeks apart and you're having hot flashes. I might check your blood work on the Thursday and see that your FSH is now quite high. It's more in postmenopausal range and your estrogen is very low. This is so typical of perimenopause. Because if I were to show you a graph, it would just look like 4 roller coasters all laid on top of each other. They're not, it's not functioning in a predictable pattern anymore. This is why all I can tell you in perimenopause is you're in perimenopause. And I can tell you that based purely on what's happening with your periods and your symptoms and your age. Now, it might be useful if you're 40 or 38 and it might be happening a little earlier than we would expect it to. And again, post menopause, there's not much point in doing the hormone testing, because if you're 1 year after your final period, I'll see that your FSH is really high, your estradiol is probably quite low. It's not giving me any information I don't already know based on your age and what's happening with your cycles. So ruling things out, yes. And I do a baseline level to make sure that nothing is very out of the ordinary. For example, sometimes a testosterone level or a prolactin level will be strongly elevated, and that can point us in the direction of perhaps looking for a pituitary nodule or an adrenal nodule or something else going on that is fully explained by the menstrual changes. And also to see sometimes if later on someone isn't responding to therapy as I would expect them to, perhaps we want to have that baseline level to look back on, but it's not essential. I start women all the time on hormone therapy without ever looking at their hormone blood work, as long as we know their basic blood work is all normal.
Well, it's kind of like, and correct me if I'm wrong, if a woman is pregnant and she's showing all the signs of being pregnant, I know, you know, but we do a test anyway, and we do other testing to make sure everything is A-okay. But chances are, if your body's responding like you're pregnant and you're feeling pregnant, you're probably pregnant, and probably no one needs a test to figure that out.
Fair. But we do it in pregnancy because we want to know as soon as possible. But you're right. Yeah. If there was no urgency, if there was no such thing as prenatal testing for any reason, right? If pregnancy in cavewoman times, let's just go back, it was like, you haven't had your period in 5 months and your stomach's growing and something's kicking. I'm no doctor, but I think you're pregnant, you know?
And if you haven't had your period in 5 months and your stomach isn't growing, I mean, this is where we do test, because there can be, when it comes to our cycles, there can be other things going on that can be indicative of that. Okay.
Yeah.
So,
and the only thing,
and I had
the only thing kicking and carrying is kicking the blankets off at night. So that's also different.
I love this. Okay. So, I mean, a good doctor who is, I mean, all doctors are great because they sign up to take care of us, but you know, they're going to be able to figure this out without having to do any testing. And sometimes I think our takeaway is like, well, you're refusing to test me, so you don't believe this is happening to me. When in reality, a good doctor doesn't need to necessarily test you to be able to treat you properly.
Exactly. It's a red flag if they are treating you based on your test results.
Ooh.
For hormones. That is a huge red flag. I know right away. So I frequently get requests or get inquiries from patients who might want to come see me in my menopause clinic. I can tell right away what kind of provider they're seeing based on what they're using for their hormone therapy. And if they say they tested my levels and they adjusted my dose based on my levels, in the vast majority of cases, that's not someone who's practicing guideline-based, evidence-based menopause care.
Okay. Do you have other red flags for us?
Yes. If you're on a progesterone or testosterone cream, neither of them have molecules that adequately absorb through the skin. So there is a progesterone estrogen patch. That's one exception. That is, well, and if you're paying out of pocket and you have a healthcare plan and you're paying out of pocket for your compounded bioidentical hormones, you're not getting evidence-based Health Canada approved care. The reason it's so crucial to get enough progesterone is that if we give estrogen on its own to a woman with a uterus, her uterine lining will get thicker and thicker over time and develop what we call hyperplasia, which is abnormal thickening, which is a precursor for uterine cancer. She may also develop polyps, unscheduled bleeding, because you need to get enough progesterone in the right way to counteract the effects of the estrogen. And that's a big red flag if you're getting progesterone through any method other than a pill taken orally or vaginally, or the combined estrogen progesterone patch. Nothing else works. I've heard it all: under the tongue, cream, you name it. No progesterone at all. That's my favorite. And I often see the complications. Pellets are a huge red flag.
Okay, this is good.
Is not Health Canada approved or FDA approved. It's a very risky way to get your hormones, and not as advertised.
Well, I think about Suzanne Summers, right?
Oh.
And her plight for hormone therapy and whatever. And she was big into bioidenticals. But you have to think back. That is a time where, look at the view on hormone replacement therapy in general. She probably had a hard time getting her hands on anything that was approved. And so I think I hear bioidenticals and I think Suzanne Summers, and that is superior, and I need to have that. I mean, that was at a time where she didn't have any other choice and she was trying to figure it out on her own. Things have changed.
I feel so terrible. I tell people all the time, when I went through medical school, I learned nothing about menopause care. Menopause doesn't exist in medical curriculum. It didn't exist in my residency curriculum. And I was trained at Sunnybrook Hospital with a fantastic gynecology and obstetrical program. And I did so much time on those wards, and I was interested in women's health. So I did a lot of extra learning in women's health. Menopause never came up. And it was just this black hole in the medical community, and it still is. And so I understand how that vacuum allowed for this huge market to develop around bioidentical hormones. It was the only option. Doctors were turning their back on women that when they needed help the most. It was like coming out of a cult when I started training as a menopause provider, because I realized everything I thought I knew was wrong.
Yeah.
We'd been so misled by the people who were there to teach us.
Yeah.
And I don't blame women at all. But my job now, my mission now, is to make sure they know the truth. Suzanne Summers got uterine cancer because she was likely given estrogen levels out of proportion to progesterone levels. Dr. Jen Gunter wrote a whole expose about this. And she did what she had to do to make herself feel better, but to write books and everything about it when this was not, studied properly, misled a lot of other women. And I see women all the time who have polyps and uterine thickening, and we have to change course because they're at very high risk of uterine cancer by being given the wrong type of hormones. Or testosterone is another great one, right? A lot of alternative providers give testosterone first line. They're very hesitant to give estrogen because I don't think they feel comfortable giving estrogen. They still see it as this risky thing. And they give testosterone because in women, testosterone gets converted to estrogen. That's the main thing that happens to testosterone in women's body. So they feel comfortable giving testosterone, but testosterone has to be carefully monitored because you want it to stay within female range. If it goes above female range, you can start to see significant side effects, some of which are not reversible. So voice changes, voice deepening, sometimes does not reverse when you correct the testosterone level. Hair loss, hair gain in places you don't want it, acne, mood changes, something called clitoromegaly, which is unusual enlargement of the clitoris. These are all side effects. They never tell you about these things when they insert that testosterone pellet under your skin, because they don't have to. They're not held to a standard that I'm held to as a physician.
Yeah.
If your hormone therapy comes without a little leaflet that tells you the ingredients, the formulation, the risks, the benefits, the side effects, you're not getting Health Canada approved hormone therapy.
Okay. So I need HRT. And how do I know what kind of HRT I need? How is that determined? Also, let's talk about dosing. I would imagine again, there are reasons why certain doctors, even when knowledgeable, are prescribing this or that. It's based on maybe your risk, your health history, all of that. So you really want to have these conversations with your healthcare provider. But for educational and example purposes, I go to you, you're like, Gina, yep, sounds like you're in menopause. Like I had a period consistent until I stopped getting it for 9 months. Like there was no change in my periods whatsoever.
Wow.
I did have a lot of symptoms, obviously a lot of night soaks, not even sweats, and night soaks. I had frozen shoulder, I had vertigo, I had heart palpitations, I had all of the things.
Yes.
Almost, it felt like, but my periods were bang on and super consistent and no changes there. But I go to you, I say, okay, this is how I'm feeling. I'm moody. I got this. You're like, it sounds like you are at the end of perimenopause or you are in between, almost at menopause. Um, you need HRT. What do I get? What are my options? What are my best forms? What's my best standard of care?
This is a great question. And I want to preface this by saying a lot of women will try to go to their doctor. And if it's not a certified menopause practitioner, you will likely have to take the lead and ask for what you want.
Yeah. Yeah.
So,
Okay.
the main form of estrogen, there's two that we give most commonly. One is Premarin, which is naturally derived from pregnant horses' urine. And has been around. This was what was used in the Women's Health Initiative. This was the original, the OG estrogen that we've had around forever, for decades.
Okay.
And then we have estradiol, which is structurally and functionally identical to what your ovaries produce. It's derived from yam products most commonly, and it is synthesized strictly in a lab to be the right dose, the right formulation, but the body kind of adjusts to it as though it's its native estrogen, which is really, really nice. And this is given through a pill, a patch, or a gel commonly. These are the most common forms in Canada. They have sprays and things in the States, but we don't have those here yet. So that would be, and typically I start at a lower dose and work my way up. It's really important to understand you may not start with the right dose. After 4 to 6 weeks, you may feel like it's not quite working very well for you, and you ask for a dose increase. I think that's reasonable. Don't give up and assume it's not going to work for you. In terms of progesterone, we do have a form of progesterone that can be given through the skin in a combined patch. We have prometrium or progesterone, which is a natural progesterone that has been micronized and made into a pill form and suspended in peanut oil. So it's important to know you wouldn't want this if you have a peanut allergy, but this is taken at bedtime. It again is structurally and functionally identical to what your ovaries produce. It's great for helping with sleep. So progesterone in capsule form is a great sleep aid too, but it's given together usually with an estrogen. The other forms of estrogen that are possible, progesterone is a Mirena or Kylena IUD. This is fantastic for women who are still having heavy periods, because it can stay in place for up to 8 years and give off a continuous low dose of progesterone that thins out and protects the uterine lining so that you can then add on some estrogen. And then, of course, there's other forms of progesterone that we still do give if somebody has an intolerance or an allergy to the natural progesterone. But those are the most common ones. There's also a fantastic medication called Duaviv, which combines a Premarin, which is the OG form of estrogen, with something called a selective estrogen receptor modifier. This is in place of a progesterone. So for someone who can't tolerate progesterone, for example, or who has very dense breasts or is very concerned about history of breast cancer or uterine cancer, it steers the estrogen away from the breasts and the uterus so that the estrogen is only focused on your brain, your bones, the rest of your body, but away from the breast and uterus. So it's like smart bombing estrogen. And this is a fantastic option. And I'm really excited to say, as of yesterday, we finally have Veoza available, or fezolinetant, on the Canadian market, which is the first non-hormonal, centrally acting, I mean, it acts directly on the brain, remedy for hot flashes. This is a great option for women who have been told and been told legitimately that they cannot have any estrogen. The downside, of course, is it's going to be for symptom management, but is not necessarily going to give you the benefits in terms of heart health, bone health that estrogen will. However, for women who are currently undergoing treatment for breast cancer, this is a godsend.
What's best? And does it depend on the hormone? Is it best in pill or patch or gel? Which is the best? Or is it?
That's where the discussion comes in. Most of it depends on cost, and most healthcare plans will cover any form of estrogen or progesterone. But if you don't have private health insurance, oral formulations are much, much less expensive. So an oral estrogen tablet, which comes in many doses, like I said, it only increases the risk of blood clot by about 1 per 1,000 per year, which is very small. And that goes back to normal, goes back to your baseline risk after 1 year of use. It's important to know. That is covered. There's also a new one on the market called Bijuva, which combines estradiol and prometrium in one capsule. So that's very convenient to take at bedtime. A lot of my patients who have private health insurance prefer the gel or the patch for their estrogen. They just are kind of done with taking estrogen by mouth. But progesterone is most commonly taken as a capsule at bedtime.
Okay. And I want to just go back quickly to the red flag conversation, because I don't want to discount privatized healthcare. If you have a doctor and they're not offering you these types of options, or what they are offering you is limited, that might be a red flag. Having to pay out of pocket is not necessarily red flag if you are going the privatized route. I just want to make that very clear. Like if you've gone and seen someone and they're asking you, you're going to have to pay for it. You probably could get the same thing from your doctor if they were open to it. This is really for people who are like, okay, my doctor is great for certain things, not all that educated in this space. I want to go talk to someone specifically about this. That might mean that I'm paying out of pocket. And so that's not the same thing. That's not the same red flag.
I need to explain. So Alberta is the only province in Canada that has a billing code for doctors for menopause care. Every other province, including Ontario, does not. So, for example, this is why you don't see doctors like myself setting up OHIP-funded medical clinics for menopause, because we couldn't afford to keep our lights on. So you do see things like Mount Sinai, which has a gynecology-run menopause clinic, but the wait is 2 years. And you get 15 minutes, often with a resident or fellow, and there's no follow-up. So that's what I hear most often. I'm not begrudging them. They're doing the best they can. They're so overwhelmed with demand. And then you see private care in terms of alternative providers, which is quite predatory. And then you have options for private care with menopause practitioners like myself, who are practicing evidence-based care. And my clinic's a multidisciplinary clinic. I work for a big organization. It's a little bit more on the pricey side. But in comparison to what people are paying naturopaths, not really. And then there's other things, like I want to mention Felix. Felix is a great option as a low-cost private option for menopause care. It's text-based, but it is wonderful certified menopause providers. And they take consults. They can start you on hormone therapy. It's a great option. There's also Bria. I really want to give a shout out to Bria, which is betterbria.com. It was set up by psychiatrists. It's a women's reproductive life clinic that offers combination of private, publicly funded care, including social workers, psychologists, psychiatrists, and nurse practitioners. Sorry, my dog is coughing. Who can start you on some hormone therapy if they feel that you would benefit from it. The only caveat is often you then have to go back to your primary care provider to continue the prescription, which can be, I know from my experience, it's very difficult to discharge patients back to their primary care provider because they treat hormone therapy like some kind of narcotic.
Yeah.
It's very unfortunate.
You need that buy-in, but this is exactly why I'm running this menopause add-on. This is exactly why I am grateful for people like you who spend the time to educate us and share your knowledge. So it saves us time. It helps us have more focused conversations with our healthcare providers. It empowers us to ask the questions we need to ask and to seek out the help. It might take you a while to find the right care. It's definitely worth doing. Before we go, I just want to clarify. I have this sense of estrogen, progesterone, testosterone. You have these medications, for lack of a better word, that help. What you are prescribed and how you get it would be dependent of the symptoms that you're having. So these different types of hormones treat a variety of different symptoms. So I would talk to you about the symptoms that I'm having, and you would come up with the combination that you think would best address the symptoms that I'm having. And then in terms of how I'm taking, you would then look at my health history and be like, this pill or patch or IUD would be best for you. And that's the nuance behind it, correct?
Yes, I offer options. Here's what, the options you have. Here's what each one might offer you. It's also the other factors. We do incorporate how do you start resistance training, right? How do you adapt? How do you adapt your lifestyle? What do I recommend in terms of, for example, alcohol consumption and supplements and things like that, which are, again, targeted supplements, not the ones you see, the menopause supplements. None of those have really good evidence, and they have a bit of a placebo effect, I think, for women who are perimenopausal, but it's really hard to say that those are going to do much more than cost you a lot of money.
You're talking like the, I don't know, feel better in menopause, miracle concoction, when you probably would do best just taking a vitamin D and magnesium and omega-3 and get your creatine in or whatever.
Yeah. The things we're often avoiding doing are the things that are going to help us the most, right? The quick fixes, they don't tend to help us. But that's right. And I do want to say, I want to leave everybody with this one story, if it's okay. It's a quick one.
Please. Yes.
When I was a family doctor back in the day, I had a patient, a menopausal woman, came to me, very highly educated woman. And she said, I have been doing my homework. I would like to try this medication, Duaviv. I'm having very bad hot flashes. I'm not sleeping. I'm concerned about my bones. And I have looked at this resource and that resource. I'm willing to waive the risk. I understand you're going to tell me there are risks. I'm willing to waive them. I think I have a good understanding of them. And I would like to try this for 3 months and see if I feel better. And then I'll come back and see you again, and we can discuss whether to continue. I was terrified giving her the prescription. I felt so sure I was giving her a prescription for breast cancer based on everything I had heard in my medical career up to that point. But I went away and I researched that medication. And I saw how safe it was. And I saw what the guidelines said. And she safely and happily continued that medication. And I learned something about hormone therapy that day as a family doctor. I am not saying you're going to waive every risk. If someone tells you, no, 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 this is a specific reason why I don't feel this is a good idea for you, that's fine. But to accept this blanket of, oh, no, no, I don't believe in hormone therapy, it's too high risk based on what I learned 20 years ago, that doesn't have to fly. Sometimes you do have to come in prepared, express yourself clearly, bring them the Menopause Society guidelines, which are widely available on their website for everybody to see and print, and let them see for themselves that they too can engage you. And this isn't a dictatorship. It's a two-way street.
I love that you said that, and this is why this is why I love you. Doctors are people too, and they're human, and I think it's all about the conversation. I think, like I share the conversation I had with my doctor 2 years ago versus a few months ago, where she said, "How are you doing?" And she's like, "Now I now have access, and I have learned so much. Let's have this conversation again." Where the first time I went into her and I was so reactive in the moment. I'm crying, I'm this, whatever. And the surface conversation was I had been under a lot of stress. There were a lot of things that I could use as excuses for the things that were happening. And she's like, "It sounds like you're under a lot of stress. Let's give you an antidepressant." Now, I didn't end up taking it, full disclosure, because I also was like, there's a lot of things I could be doing. Exercising every day, stop drinking, those things. Wasn't opposed to it. That can be a life raft for people. But when I had the conversation with her recently, 2 years later, it was a completely different conversation, and I know for a fact that if she knew what she knows now back then, it would have been a different conversation, but I'm gonna take responsibility. If I would have known what I know now, that would have been a different conversation 2 years ago, and that's my passion for having these conversations, is to inform our members, the people listening, and your doctor should be open to what you're saying. It shouldn't be a dictatorship. They should at least be like, "Why do you think that? And what are you suggesting? And what would you like to try?" And even if it's you go to your doctor and then you walk away and do more research and then come back, right? Like, I
Completely.
love that.
Completely. Do your research, do your homework. It's available. I often find my patients come to me now better informed than their family doctors. It's widely available. We're so lucky to live in an information age. You just have to learn how to separate the valid from the advertisements, like the things that are not necessarily as sold.
Yeah, and this is because this is new, right? Like, I'm not gonna go to my cardiologist and do my own, like, Google research and be I mean, I might have done that in the past where I had an issue with, one of the prescriptions that my ex-husband at the time was having. It was causing him to cough. I did some research, talked to other doctors, and I said, "Hey, this one seems to be making him cough." And he's like, "Okay, let's just switch that out, change that, whatever." They were very open to that. Now, I said, you can't do your research in other areas, but this is so new. The space is really new. We're not suggesting you go and challenge your doctor on every little health issue that you have, but the space is new here.
I mean, it's new that we're reinterpreting. It's new to the doctors. That's what's funny is again, we didn't learn about this at all. And what a sad downstream effect of not learning about it is I can't even count how many women I've seen over the years in family practice as a trainee and then as a doctor, and never had an opportunity to renew their prescriptions, ask them how they were feeling, hear the benefits of it, because they weren't on it. For
Yeah.
20 years, there wasn't a single woman I ever saw on hormone therapy.
Right?
So how are we going to learn? I would have loved it. It could have changed my life if 15 years ago someone had come into Sunnybrook and said, "I'm on estrogen and progesterone, and I can't even tell you how great I feel. This is fantastic. I can't believe it." And someone told me that all the stuff about breast cancer was a lie. And I would have said, "Oh my goodness, really? I have to go look into this." But when you don't have that opportunity, you don't go chasing the information. So I think we have to
Yeah.
set our doctors off to chase that information. I
Okay.
can still be plenty busy in what I do, troubleshooting the more complex cases. If family
Yeah.
doctors just get comfortable, just start people off on the basics,
Yeah.
I'll help you if it's complex, but there's less than 2% of eligible women are on hormone therapy right now.
Yeah, that's craziness. Okay,
Absolutely.
fine. Final question for you. I start taking HRT. How soon until it helps me lose weight? My hot flashes are gone. I want to have sexy time all day, every day. Like, when does this miracle drug kick in?
Variable. So for hot flashes, for sleep, and for mood, I find those things tend to get better pretty quickly. I don't promise within days, but I have heard many women tell me it's within days. I'll say
Wow.
within a few weeks. The
Okay.
full effect should be felt by about 4 to 6 weeks, which is why I don't recommend changing the dose within the first 4 to 6 weeks. Okay. Sexy times is multifactorial. You have to make sure vaginal discomfort, dryness, frequent bladder infections, exhaustion, they're all factoring in. It's not just about replacing the estrogen, but again, couple months, you should start to notice some improvement once those factors start to improve, because chronic fatigue takes a lot of good nights to recover from, right?
Yes.
Weight loss, that's the long game. It doesn't happen just because you start the hormones. The hormones help the things you then do with it to work better. And slow, sustained weight loss happens about the 6 to 12 month mark. But I hear women often tell me at the 3-month mark, I feel like the out of control weight gain is kind of stopping. Like I kind of feel like I have a bit of control back over it. But the ones that do go on to experience weight loss are incorporating the things that you talk about, are incorporating their strength training, are making those lifestyle changes, are getting that 7 hours of sleep. So
yeah, amazing.
Tricky, but it's different timelines for different results.
Thank you so much for taking the time. What an informative, clear, concise conversation. I feel empowered. I feel hopeful. I'm excited that I know there are things that I can do. I feel like I have a good sense of what's available and why. I have a good sense of why there are concerns. I also have a good sense that maybe they're not all, concerns I need to be concerned about, even though I've heard that I do. I'm going to have an informed conversation with my healthcare provider, figure out what I can do, what's right for me, and then feel confident in the choice that I'm making. And that's all because of the conversation you've had with us today. So thank you so much.
Thank you so much for having me. I'm glad I could be here to help.
So where can people find you? That's the big question. Everyone's going to be like, where can I find Dr. Jennifer?
Yes, I practice at Medcan Toronto, and I'm very proud to say that I gently pressured them to open my program up to people who are not necessarily Medcan clients. We have something called a standalone program where if you need you just have to have an up-to-date mammogram and we get you some up-to-date blood work done for cardiovascular health, thyroid, all of that. Once that's done, I can see you and start your menopause journey with you. So that's the best way to find me. That's where I practice. And of course, on Medsplaining, I educate all day long about hormone therapy, menopause, perimenopause, and all things women's health.
Okay, so Medsplaining, that's your Instagram account. That's you have a podcast.
Podcast, yeah.
Podcast as well. Guys, can you just put up on the screen again, medcan.com, medcan.com/menopause and perimenopause. Doctor, for everyone joining us, I know that you found this conversation super helpful. I don't even need to ask. I hope you got just as much out of it as I did, which is a lot. Dr. Jennifer Zelovitsky, I am so grateful for you, appreciative for you. Honestly, thank you, thank you, thank you.
Thank you for having me, Gina. Take care.